As always, this is a busy year for myeloproliferative neoplasms at ASH. Well, maybe I shouldn't say as always, but as in recent years, there's really been an explosion in the field of interest in drug development and just the profusion of studies, lots of attention on MPNs this year again. So I would say, it's always kind of hard to pick the highlights because there's so much out there that is good. But let me just divide it real quick into two sort of broad categories. One is the new drugs, which is a huge space, and I'll try to do justice to that, and also abstracts or presentations which are not new drugs, but at the same time are thought-provoking and perhaps practice-changing. So I want to quickly mention that at the first oral session, there was a really nice abstract by Francesca Palandri in which she really looked at risk stratification for polycythemia vera, which for ages really hasn't changed. It's just been age and prior thrombosis history. And we all realize intuitively that there's a lot more to it. And she was able to kind of objectify this. I think it was called the PV ARC study out of Italy. And I would urge our viewers to check that out. She looked at many other factors, and maybe we are now on the cusp of refining our risk stratification in PV with more than just age and thrombosis history. Along those lines, I thought there was a very interesting abstract presented by Claire Harrison's group out of the UK, where they looked at ET and they looked at mutant calreticulin, which is the driver mutation in about 30% of cases of ET. And they looked at the usual therapies we use, which are hydroxyurea, anagrelide, interferon, and ruxolitinib, and they looked at what happens to the dynamics of mutant calreticulin over time. And they were able to show, unsurprisingly, that it goes down on interferon and ruxolitinib and actually goes up on hydroxyurea and anagrelide. So not only does it not go down, actually goes up. And they raised a very thought-provoking question, which was, could it be that the increased fibrosis that we know that anagrelide has been associated with in ET, could it be driven by the fact that this CALR mutation burden is actually going up, because we know that that may be implicated in fibrosis. There was also a very intriguing abstract presented on pulmonary hypertension in MPN patients, particularly myelofibrosis patients, and how that can be linked not only to adverse cardiovascular outcomes, but also hematologic progression. So I thought that was very interesting. And then if we move into the new drugs, which of course are always the bulk of the presentations and also my area of interest, I think there's again a lot to talk about, but I'll just maybe name a few that are worth mentioning. So naftamadlin is making big news at this ASH Congress. Two oral presentations from their Boreas study, phase 3 study, looking at naftamadlin, the MDM2 inhibitor from Kartos, in myelofibrosis patients who failed a JAK inhibitor versus best available therapy. Very, very nice correlative data already presented, and the clinical data to be presented this afternoon. And then there are a number of other drugs. Yesterday at one of the oral sessions, we heard about the Sumitomo PIM kinase inhibitor TP3654, or nuvisertib as it is now called, the Incyte BET inhibitor INCB 057643, and then a very intriguing anti-hemojuvelin antibody for anemia. Now, all three of these are applicable to myelofibrosis, and all of these seem to be very active drugs that we need to watch going forward. The anti-hemojuvelin antibody, again, being something that would downregulate hepcidin and help anemia in that sense. And then today, looking forward to the oral presentation this afternoon, beyond the naftamadlin that I already mentioned, I'm excited to hear the results of elritercept. This is a novel activin receptor ligand trap from a company called Keros, and this will be presented by Claire Harrison. This is also an anemia agent in myelofibrosis, also being developed in MDS. So, sort of in the class of, say, luspatercept, but a different molecule, and with some very intriguing benefits, perhaps beyond anemia. And finally, I'll close with something very, very novel, at least for this field, cellular therapy. So my colleague Lucia Maserova will be presenting today the umbilical cord derived regulatory T cells, small set of patients, only 9, but some very intriguing results with this absolutely brand new way of attacking the disease. So this is in combination with ruxolitinib. As always, with the 4 oral sessions and all these poster sessions, there's just a lot out there. But I think what I try to do here is cover the drugs I'm most excited about, and then some of the non-trial abstracts that could still really change the way we think about things. I'll give you an example. We have always regarded high platelets as not correlating with the risk of thrombosis. Even though it may seem counterintuitive, studies have failed to show a correlation between high platelets and the risk of thrombosis in ET or PV. But there are some data sets now emerging that are suggesting that that may not be the case. One was REVEAL, which is a large study, 2,500 patients with PV. That's already published. But there was a study yesterday at one of the oral sessions, and again, it starts to run together when you're here, and there's so much that you're new that you're listening to all day. So I'm not able to recall right now which exact study, but I think it's important to say that I think we are now seeing some large data sets which are suggesting that no, the platelet count may actually matter for thrombotic risk. I think this, the last has not been said on this topic. I think this remains somewhat of an unresolved question, but I'm intrigued by some of the information that's coming out.